It's interesting how there's a divide now on where tandem or double transplants for myeloma are performed. In European guidelines, it's very strongly suggested that patients with high-risk disease, which means ISS stage 3, high-risk cytogenetics, should be strongly encouraged to go through double transplants because they have been associated with a significant survival benefit in randomized trials. The American experience with tandem versus single in the initial readout of the Stamina trial showed no benefit for tandem transplant. However, in a long-term follow-up analysis that was recently presented by Dr. Parameswar and Hari at the ASCO meeting, there showed a benefit for progression-free survival benefit for patients who underwent a tandem transplant and who underwent a tandem transplant. That was, they were treated with what they were assigned with, as compared to those who were assigned to the other two groups or who did not get transplanted. So I think in the United States, particularly because there's access to so many salvage treatments, and the true question, the true way of defining the role of tandem transplant is that you would randomize patients to a tandem up front or a single transplant with the option of a salvage transplant in the event of relapse, and see if there's and see what the impact on survival is. I personally, if I'm doing a tandem transplant, I would do a tandem transplant in young patients who have high-risk disease, but the second transplant wouldn't be an autologous. The second transplant would actually be an allogeneic. I am doing tandem transplants in older patients who present with plasma cell leukemia, and there I would do 2 autologous transplants if they're not candidates for an allogeneic transplant.